Seats, everybody. Thank you, delegates. Please take your seats. Just wait for the last couple of stragglers and we'll get underway. Well, good morning everyone. Good morning delegates, good morning guests. Welcome to Canberra for the 2018 AMA National Conference. What a fun weekend we're going to have, in more ways than one. So just a few things to note before we get underway. On the back of your name tags, you will have the web access details, both the login and the password. There's also the Twitter hashtag of AMA NatCon, so make sure that's kept busy all weekend. This time, for the first time, we've also provided ribbons for you to identify yourselves so that you can group together in your tribes when you feel like congregating. So there's no competition for who has the most ribbons, although there's clearly some subterranean contest underway because there's quite a few that some are wearing. But it's a good way to meet people who have a similar interest in practice that you might have. So make sure you connect up. Important information, bathrooms are outside the conference room on the left, both men's and women's, and my left, your right. And I need to tell you about fire evacuation procedures. So if there is a fire, then an alert siren will sound, and that's a continuous beeping sound, and that will be activated immediately. An announcement will be made by hotel staff instructing you what to do while the alarm is being investigated. If it's a false alarm, you will be notified by announcement. That if evacuation is required, the evacuation siren will sound, and that's the continuous whooping sound. In that case, you should go to the nearest fire exit, and there are two assembly points. One is in the car park at the rear of the hotel, the other is through the front of the hotel, and on the right-hand side of the hotel as you face the street, there's a grassed area in front of the adjacent apartment building. So assemble in one of those two places. Don't stop to collect your belongings, but head straight to those areas. So with all of that information, there'll be lots more housekeeping to come, but with all of that, let's get underway. And if I could ask you all to please stand for the arrival of the office bearers of the AMA.
Please sit down. my traditional greeting. My name's Bev Robotham. I'm the Chair of Federal Council, and on behalf of Federal Council, I welcome all delegates and members and observers to National Conference of the Australian Medical Association, the home of Australia's doctors, and the premier health policy organisation for Australia. Well, we're delighted to see you. We're very excited about the program we've put together, and we hope you'll be excited by it too. Now, I'd like to begin by acknowledging the Ngunnawal people, who are the traditional custodians of this land on which we are meeting, and pay respect to the elders of the Ngunnawal Nation, both past and present. And I extend this respect to all Aboriginal and Torres Strait Islander peoples in attendance today. I'd like to invite Tina Brown, a Ngunnawal elder, to the stage for Welcome to Country.
Thank you. Good morning and welcome to the beautiful lands of the Ngunnawal. I begin by acknowledging my parents, Carl and Louise Brown, and all of the Ngunnawal elders and ancestors. I live my life in honour of you and the legacy you have passed to me. Many of you will know that Canberra is a local word meeting place. We would say that the leaders of our nation and surrounding nations have been meeting on this land forever. Our oral stories and signs tell us that we have been meeting in this area for more than 25,000 years and or more than 100 generations. Our people have been able to maintain this continuous connection because the country provided fresh air to breathe, clean water to drink, nourishing food to eat, and clothing and shelter to keep us warm through our bitterly cold winters. It is on this once exacting land, as the extreme cold of the last ice age was easing, that my ancestors forged their resilience and grew their knowledge of country and handed to those of us who follow them the legacy of our ancestral beings and our creation stories and our responsibility for the future of our people and country. They form pathways across this land to guide us. These pathways were formed as our ancestors followed the river and creek corridors and the ridges and spurs on the hills and mountains linking our major spiritual and gathering places. The responsibility for the future of our people and country now rests with all of us. So on behalf of the elders of my people, my extended family, and all who have gone before us, I welcome you to the ancestral lands of the Ngunnawal. I welcome my Indigenous sisters and brothers and am in awe of our legacy, tens and thousands of years in the making. I also welcome our fellow Australians and honour the mingling of the dust of the bones of my ancestors and the dust of the bones of your ancestors, for it is this which now shapes the land, uniting us all as custodians of the future. Welcome to the beautiful lands of the Ngunnawal.
Thank you, Tina. I'd now like to welcome Tony Maxfield to the stage to sing the Australian National Anthem. Tony Maxfield has more than 20 years' experience as a vocalist and performer. She's a reservist in the Australian Army with the Royal Military College Band Untroon, and she regularly performs with a variety of Canberra's corporate and jazz bands. Can I ask you all to be upstanding? Welcome, Tony.
We've golden soul and
Now I'll ask you to stay standing because we're now going to read the Declaration of Geneva. So the background to this, the Declaration of Geneva, the Physician's Oath, was originally adopted by the General Assembly of the World Medical Association at Geneva in 1948 and has been amended in 1968, 83, 94 and 2017. It's a declaration of a physician's dedication to the humanitarian goals of medicine, a declaration that was especially important in view of the medical crimes which had been committed by Nazi Germany. The Declaration of Geneva was intended as a revision of the Hippocratic Oath so that it presented that oath's moral truths in a more modern way. So please join with me with reading the Physician's Pledge. As a member of the medical profession, together, I solemnly pledge to the health and well-being of my family. My patient will be my first consideration. I will respect the secrets that are confided in me, even after the patient has died. And I will maintain my power, the honour and the noble traditions of the medical profession. My colleagues will be my sisters and brothers. I will not permit considerations of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation. I will not use my medical knowledge to violate human rights and civil liberties, even under threat. I make these promises solemnly, freely, and on my honour. Thank you. Please take your seats. It's now my pleasure to introduce the President of the Australian Medical Association, Michael Gannon. Michael, last time I introduced you at this meeting a year ago, I likened you to a 400-metre runner halfway through your race. It's my firm view that the 400-metre run, the most gruelling of athletic events, is the best analogy for the AMA presidency, as it requires endurance, speed, and a kick on the home straight. So Michael, you've come home strongly. We congratulate you on your race and the way in which you ran it. We thank you for your service to us, and we look forward to your post-race analysis.
Delegates, ladies and gentlemen, I would also like to welcome you all to National Conference, my second and final as Federal President. We are joined at this conference by a number of special guests. I would first like to acknowledge the presence of some former AMA presidents at this conference, and I'll ask them to stand as I name them. Would you please welcome Dr. Bryce Phillips, President 1988 to 1990. Dr. David Brand, President 1998 to 2000. Professor Karen Phelps, President 2000 to 2003. Dr. Bill Glasson, President 2003 to 2005. Dr. Mukesh Haikawal, President 2005 to 2007. Associate Professor Rosanna Capilingua, President 2007 to 2009. Dr. Andrew Pesha, President 2009 to 2011. And Dr. Steve Hambleton, President 2011 to 2014. The last 6 of those presidents will join me on the stage this afternoon. During that session, we will look back over almost 2 decades of AMA leadership in policy and advocacy. The AMA is pleased and honoured, as we are at every conference, to have with us some very distinguished overseas visitors. As I read your name, would you please come forward to the stage for a gift from the AMA as a token of our appreciation for your attendance. Please welcome, from the British Medical Association, the BMA Treasurer, Dr. Andrew Dearden. Born in Wales, Andrew spent many of his early years in Australia. He's a dual citizen, therefore disqualifying him from service in the Australian Parliament. From the Malaysian Medical Association, we welcome their president, Dr. Ravindran Naidu. We never stop talking about politics, and we are looking forward to the insights on the recent Malaysian election.
Thank you very much for having me here. It's a pleasure. Thank you very much. It's my pleasure.
From the Medical Association of Thailand, Secretary-General Professor Prakitpuntu Tomikchong, who for obvious reasons is more commonly known to me as POM. He is also Deputy Secretary-General of the Medical Association of Southeast Asian Nations, MASEAN. Welcome. From the New Zealand Medical Association, we welcome their chair, which is a bit like their president, Dr. Kate Baddock. So I recommend that we all avoid the topic of talking rugby union when we talk to Kate this weekend. Nothing good ever comes up when you talk to New Zealanders about rugby. Also from the New Zealand Medical Association, we welcome their CEO, Ms. Leslie Clark. And as an obstetrician, I'll also be talking to them about Prime Ministers having babies. It's always exciting to host our friends from medical associations around the world. I've had the great fortune of meeting those 5 individuals previously on my travels to international meetings. Please introduce yourself to them while they are here with us in Canberra. There are so many good stories about how our profession and associations operate globally. President 1998 to 2000. Professor Karen Phelps, President 2000 to 2003. Dr. Bill Glasson, President 2003 to 2005. Dr. Mukesh Haikawal, President 2005 to 2007. Associate Professor Rosanna Capilingua, President 2007 to 2009. Dr. Andrew Pesha, President 2009 to 2011. And Dr. Steve Hambleton, President 2011 to 2014. The last 6 of those presidents will join me on the stage this afternoon. During that session, we will look back over almost 2 decades of AMA leadership in policy and advocacy. The AMA is pleased and honoured, as we are at every conference, to have with us some very distinguished overseas visitors. As I read your name, would you please come forward to the stage for a gift from the AMA as a token of our appreciation for your attendance. Please welcome, from the British Medical Association, the BMA Treasurer, Dr. Andrew Dearden. Born in Wales, Andrew spent many of his early years in Australia. He's a dual citizen, therefore disqualifying him from service in the Australian Parliament. From the Malaysian Medical Association, we welcome their president, Dr. Ravindran Naidu. We never stop talking about politics, and we are looking forward to the insights on the recent Malaysian election.
Thank you very much for having me here. It's a pleasure. Thank you very much. It's my pleasure.
From the Medical Association of Thailand, Secretary-General Professor Prakitpuntu Tomikchong, who for obvious reasons is more commonly known to me as POM. He is also Deputy Secretary-General of the Medical Association of Southeast Asian Nations, MASEAN. Welcome. From the New Zealand Medical Association, we welcome their chair, which is a bit like their president, Dr. Kate Baddock. So I recommend that we all avoid the topic of talking rugby union when we talk to Kate this weekend. Nothing good ever comes up when you talk to New Zealanders about rugby. Also from the New Zealand Medical Association, we welcome their CEO, Ms. Leslie Clark. And as an obstetrician, I'll also be talking to them about Prime Ministers having babies. It's always exciting to host our friends from medical associations around the world. I've had the great fortune of meeting those 5 individuals previously on my travels to international meetings. Please introduce yourself to them while they are here with us in Canberra. There are so many good stories about how our profession and associations operate globally. Thank you. I've got written down that you're introducing the video there. Ngunnawal people, I acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. I would also like to acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending this conference. The last year has been a very busy and very successful year for the Federal AMA. In fact, it's been a very busy and very quick 2 years for me as President. Throughout the last 12 months, your elected representatives and the hard-working staff in the Secretariat in Canberra have delivered significant achievements in policy, advocacy, political influence, professional standards, doctors' health, media profile and public relations. We all worked tirelessly to ensure that health policy and bureaucratic processes were shaped to provide the best possible professional working environments for Australian doctors and the highest quality care for our patients. The unique role of the AMA in health advocacy is what we are looked to for commentary on the breadth and depth of health policy, social policy and the health system. This privileged role is no more evident than on budget night, held a fortnight ago here in Canberra. We were there at the Health Lock-up in the Hellenic Club in Woden with all the other associations, societies, colleges, federations, lobbyists and advocates to hear and read the details and entrails of the budget. Both of my phones were off, if only briefly. I assure you the health budget papers are thick. They cover everything, the announcements, and of course the things that are not announced, the hidden detail, if you like. So in the lockup, you have about an hour and a half to read the lot, listen to the gloss from the ministers and the department, and search through the dross for the things the government might prefer to have unseen or unsaid. You prepare your budget response in that time and then escape the lockup to run off to Parliament House and give the media your verdict. The public health people talk about the public health bits. The hospital people talk about the hospital bits. The various body organ groups talk about the body organ bits. The consumer groups talk about the consumer bits. The rural groups talk about the rural bits, and on it goes. I was delighted for Sarah Brown and Purple House when I saw they got their new Medicare item number for remote renal dialysis. But of course the AMA has to be ready to talk about all the bits of the health system, how they fit together and how the budget will or will not keep it working. That takes a fair bit of work. And budget night is a microcosm of what the AMA does and does well. All year round, year on year, we get asked about everything in the health system and everything that affects the health of individuals and the community. Importantly, we always have the right answers. Thank you, Catherine. It is our collective honour to have this leadership role, and we have been very active in it over the past year. Following on from the highlights video we've all just seen, I'd like to run through some of the greatest hits of 2017-2018. Our strong and robust advocacy led to the decision to lift the freeze on Medicare patient rebates. We did not get everything we wanted in the time frame we wanted it to happen, but we got the right result. Sometimes in advocacy, you have to take your wins in increments. A win is a win is a win. And hello to all the West Coast Eagles supporters in the audience. A lot of organisations get nothing for their efforts. To be successful in Canberra, you have to learn to take the knocks along with the wins and go back again and again for a better outcome. It is breathtakingly naive to think it works otherwise. And that is what we've done and keep doing. In 2017, the AMA launched its regular Safe Hours audit report, which gave added focus to the emerging issue of doctors' health. To enhance this focus on doctors' health, AMA coordination of doctors' health services continues all around the country, with funding support from the Medical Board of Australia. We maintained a strong focus on medical workforce and training places, which resulted in the National Medical Training Advisory Network significantly increasing its workforce modelling work. We secured a number of concessions in the proposed redesign of the Practice Incentive Program, the PIP, as well as a delay in the introduction of the changes. The AMA lobbied at the highest level for a more durable solution to concerns over pathology collection centre rents. We focused on effective compliance, and in doing so achieved a fair balance between the interests of GP members and pathologist members. We led the reforms to after-hours GP services through medical deputising services to ensure that these services are better targeted and there is stronger communication between them and a patient's usual GP. We successfully lobbied the ACCC to renew the AMA's existing authorisation that permits GPs to engage in intra-practice price setting. This potentially saves GPs thousands of dollars every year in legal and other compliance costs. We ensured there was a proportionate response from the government in response to concerns over the security of Medicare card numbers. This avoided more draconian proposals that would have added to the compliance burden on practices and added a barrier to care for many patients. We fundamentally altered the direction of the Medical Indemnity Insurance Review. This is possibly the greatest example of Minister Greg Hunt's engagement with the portfolio. Some, not all, ministers have the intellect to grasp the detail of a complex policy issue. You had not only that, but the wisdom to trust the advice that you're being given. Indeed, we raised the importance of medical indemnity to medical practice at the highest level, I hope, in helping to ensure the review was not used as a blunt savings exercise, recognising the policy triumph that the indemnity rescue package was, not only for the AMA and the Howard government, but for patients by ensuring a safe and secure system to protect independent medical practice. The AMA campaigned on the issue of doctors' health and the need for COAG to change mandatory reporting laws, heavily promoting the WA model. I hope that we finally achieved a good outcome at the most recent COAG Health Council, at which I had the rare honour of addressing health ministers. But it's time for them to act. Healthier doctors provide even better care. let us be able to take our own advice and be able to seek help early. It's a great privilege being a doctor. The community affords you a status, and usually for activity discourages innovation and is inadequate in addressing the demands placed by an ageing population. We prosecuted the case for vastly improved private health insurance products through membership of the Private Health Ministerial Advisory Committee, through my annual National Press Club address, an appearance before a Senate Select Committee, and regular and ongoing media and advocacy. This work was complemented by the launch of the AMA Private Health Insurance Report Card. We successfully lobbied for a fundamental change in the direction of the Anaesthesia Clinical Committee of the MBS Review. The Australian Society of Anaesthetists were grateful for our assistance and leadership. Many other colleges, associations and societies have worked out that partnership with, rather than competing with the AMA, is the smartest way to get results. We launched a new AMA fees list with all the associated benefits of mobility and regular updates. We saw a number of our aged care policy recommendations included in a number of government reviews. We lobbied against what could easily have been an ill-thought-out UK-style revalidation proposal. Our work resulted in a vastly improved professional performance framework based around enhanced continuing professional development. The AMA provided strong leadership right across the busy public health landscape over the past year. With the support of the Minister for Indigenous Health, Ken Wyatt, we launched the AMA Indigenous Health Report Card, which this year focused on ear health and specifically chronic otitis media. Yesterday, the Federal Council endorsed the Uluru Statement from the Heart, acknowledging that recognition is another key social determinant of health for Aboriginal and Torres Strait Islander Australians. We released an updated AMA policy statement on obesity, a product of a policy session from last year's National Conference. I think it's inevitable we will inevitably see a tax on sugar-sweetened beverages similar to those recently introduced in Britain and Ireland. In fact, it's so simple, so easy and so obvious, I worry that it will be seen by a future government as a silver bullet to what is a much more complex health and social policy issue. We launched the AMA position statement on an Australian Centre for Disease Control, which was welcomed by experts in communicable diseases. We released the AMA position statement on female genital mutilation, providing a platform for the AMA to engage in advocacy on preventing that abominable practice. We released the AMA position statement on infant feeding and maternal health, seeking to find that common sense balance between developing measures to increase breastfeeding rates at 3 months, 6 months and 12 months, while calling for a bit more understanding and compassion for those mothers who, for whatever reason, cannot nourish their baby that way. We released the progressive and widely supported AMA position statement on harmful substance use dependence and behavioural addiction, or addiction for short. And no, I do not have a deeply held personal vendetta against pill testing at raves, or cannabis, or e-cigarettes. Like everything else, it is the Federal Council's policy, and I'm sorry to those advocates for change, but it's based on the available scientific evidence. We successfully lobbied against the proposal to drug test welfare recipients. This included a strongly worded submission to a parliamentary inquiry on the proposal, which resulted in defeat of the proposed measure in the Parliament. We hear the Turnbull government will again try to reintroduce this legislation. The AMA will again work to defeat it. We released the AMA position statement on firearms, generating considerable media coverage and interest in Australia and overseas, enabling me to achieve a lifelong ambition of being on the radio in Texas. It is important that Australia maintains its tough approach on gun control. It is vital that the AMA remains at the forefront on this call. We conducted ongoing and prominent advocacy for the health and wellbeing of asylum seekers and refugees. This included a meeting with the then Minister for Immigration and Border Protection, Peter Dutton, and lobbying on behalf of individual patients behind the scenes. Our advocacy on behalf of these individuals and cooperation with the Australian Council for International Development continues. I acknowledge the announcement of a new Chief Medical Officer of the Department of Home Affairs yesterday. We promoted the benefits of immunisation to individuals and the broader community. Our advocacy has contributed to an increase in vaccination rates. We push closer to being able to celebrate 95% rates in children. We've been prominent on maternal vaccination and seek greater penetration rates more broadly with adult vaccination. I wrote to Minister Hunt calling for the establishment of a no-fault compensation scheme for that very small minority of individuals injured by vaccine administration. It is essential that, in the absence of such a scheme, that the National Disability Insurance Scheme works for these patients. It is essential to the community's ongoing support of population-wide immunisation programs. We provided strong advocacy on climate change and health, among a broader suite of commentary on environmental issues. We consistently advocated for better women's health services and released a first ever statement on men's health. We have released new position statements on mental health, road safety, nutrition, organ donation and transplantation, bloodborne viruses and rural workforce. We promoted our carefully constructed position statement on euthanasia and physician-assisted suicide during consideration of legislation in Tasmania, Victoria, New South Wales and Western Australia. That advocacy was not universally popular. Our position statement acknowledges the diversity of opinion within the profession. It also acknowledges the need to consider the possible negative impact on the rest of the health system. Like the American Medical Association, the other AMA, we stand firmly against euthanasia and physician-assisted suicide, while acknowledging that legislation has been introduced in some states and that thoughtful, morally admirable individuals hold diverging yet equally deeply held and well-considered perspectives on the issue. We must look at the European experience, at the rejection of euthanasia and physician-assisted suicide by all Scandinavian countries and by Britain. We must heed the cautionary tale of the Benelux countries with the ever-expanding reach of their assisted suicide laws. There is no such thing as critical neutrality. You have to stand for something and be heard. Thus, we led the medical community by being the first to release a position statement on marriage equality and advocated for the legislative change that eventuated in late 2017. I had face-to-face meetings with Prime Minister Malcolm Turnbull, Opposition Leader Bill Shorten, Health Minister Greg Hunt, Shadow Health Minister Catherine King, Greens Leader Dr Richard Di Natale and a host of ministers and shadow ministers. We organised lunch briefings with backbenchers from all parties to promote AMA policies. In July 2017, our advocacy was publicly recognised when the Governance Institute rated the AMA as the most ethical and the most successful lobby group in Australia. I met regularly with stakeholders across the health sector, including the colleges, associations and societies, other health professional groups and consumer groups. The highlight of the 2017 international calendar was the annual General Assembly of the World Medical Association. Outcomes from that meeting included high-level discussions on end-of-life care, climate change and environmental health, numerous other global, social and ethical issues, and seeing the inclusion of doctors' health as a core issue in both medical ethics and professionalism. I get goosebumps when I read aloud the Declaration of Geneva like we did this morning. It is a source of immense personal pride that I was intimately involved with its latest editorial revision, only the fifth since 1948. But our focus remained at home, and your AMA was very active in promoting our mission, leading Australia's doctors, promoting Australia's health. We had great successes. We earned and maintained the respect of our politicians, the bureaucracy, and the whole health sector. We won the support of the public as we have fought for a better health system for all Australians. I was elected president in the middle of an election campaign. The combination of a knife-edge result, a one-seat majority, and the bruises felt by the Turnbull government after the Medi scare made it a difficult environment to champion serious health reform. A health system that pays a GP more to inject Botox than visit a residential aged care facility is broken. A system that regularly has acute mental health patients languishing for hours or days in emergency departments is broken. An aged care system and a wider society that tolerates abuse of the elderly, that if it was visited on children, would see individuals jailed and corporations penalised, is broken. But reform is and has to be incremental. We have to engage issue by issue on things like the MBS reviews, the introduction of the My Health record, and the workings of the Private Health Ministerial Advisory Committee. My successor will learn quickly that delivering a just, morally or intellectually correct argument does not mean things just happen as if by magic. As the end of my term as president of this amazing organisation draws near, just 48 hours away, I look back fondly and with pride at the events, incidents, agreements, arguments, successes and adventures that are part and parcel of the job, for those who have gone before me and for those who will follow. Being AMA president puts you at the centre of health policy and politics in the nation's capital, more so than almost any other role in advocacy and lobbying in this country. Being a state AMA president is demanding and significant. In my view, it is a prerequisite to step up to a leadership role in the federal AMA. The federal presidency takes things to a whole new level. The number of policy issues to grapple with is multiplied many times. So too the number of meetings. You must deal personally, often face-to-face, with ministers, shadow ministers, MPs and senators from across the political spectrum, plus their staff and their departments and the bureaucrats. You might not get much notice. It might be very early or very late. You're on a first-name basis with the Prime Minister and the opposition leader. Yes, the AMA president is very much in the game. Prime Minister Turnbull's decision to move Greg Hunt into the health portfolio was clever and inspired. I was driving through Harvey when the PM telephoned me. Beef country, dairy country. I wanted a GP locum there. The Prime Minister asked me who I wanted as Health Minister. I told the Prime Minister it's not my job to nominate the Health Minister, but I simply requested someone who had the seniority and the authority to fight for Australians and their healthcare in Cabinet and ERC. The new Minister wanted to work with us from minute one. I was watching the telecast down in Dunsborough. My wife and children were still asleep, but my telephone rang literally as the PM's press conference was finishing. That relationship has grown, matured and endured, delivering for AMA members and all Australians. I thank Greg Hunt for his deep engagement and his willingness to listen and learn. I hope that this will continue with my successor. In closing, I must say that it has been a huge honour and privilege to serve the AMA and the medical profession as Federal President. It is demanding, challenging, rewarding and life-changing. The issues, the experiences, the depth and breadth of policy and ideas and the interface with our political leaders in the Parliament are unique to this job. The responsibility is immense. The payback is the knowledge that you can achieve great things for the AMA membership, the whole medical profession, and most importantly, the community and the patients in our care. I didn't need an alarm clock the whole 2 years of my presidency. The dawn chorus was the Australian media. Rarely a morning went by without a call from a breakfast news program. Calls to Perth from East Coast media during daylight saving were not necessarily a particular highlight. It has carried a personal cost. My blood pressure is higher. I've been away from family and friends often, sometimes for long periods of time. Social media is a very effective tool, but it offers greatest encouragement to the noisiest, not necessarily those with something important or intelligent to say. The haters will hate, and neither the critics, nor in fairness the fans, seem to understand the hundreds of hours involving many different people of thought, research, endeavour and debate that go into our policies and position statements. I've enjoyed great support from many people. I've spent hundreds of hours on aeroplanes. I cannot end my time without praising Qantas, that great Australian company that's been looking after Australians for 98 years, and for me over 2 years in the Presidency on about exactly 98 individual trips. I recently did the count. I've been to every state and territory at least twice. I've represented the AMA in Thailand, Japan, Taiwan, the United States, New Zealand, Britain, Latvia and Zambia, plus 15 trips to Sydney, 28 trips to Melbourne, and now my 36th and final trip to Canberra as President. It has been tough, but it has also had many, many benefits on a personal and professional front. I thank you all for your support, confidence and friendship. The AMA is a wonderful organisation that does many good things for many people. I congratulate Dr Dilip Depilia and Dr Julian Raitt on their recent elections to state presidency. There is much healing to be done in the great states of Queensland and Victoria, many members to attract back to the cause. From time to time I've been praised by non-members for the job that I've done, usually accompanied by a story of a past grievance against the AMA. It is a broad church. No doctor agrees with everything the AMA President says. Even I don't agree with everything I say. Good time to have a drink of water. But I would encourage all doctors to think about what we achieve on behalf of all of them, member and non-member, every day of the year. Through our relationships with and advocacy to AHPRA and the Medical Board, the medical indemnity industry, government and the bureaucracy. Fighting for their clinical independence, for public health, for the health of Australia's First Peoples, for evidence-based prevention measures, and in their name for those without a voice. I would like to give special thanks to some key people for helping me get the job done. My Vice President, Tony Bartoni, especially for helping with the heavy media workload. If the Presidency was decided purely on loyalty and decency this Sunday, we could put the pencils away now. Thank you to my obstetrician and gynaecologist colleagues in Perth, particularly Dr Richard Murphy. Nearly every week I had to telephone someone to announce my next trip away. The extent to which my colleagues, my staff, and indeed my patients have bought into what I've been trying to achieve over 4 years as State President and then Federal President has been genuinely humbling. I remember my late colleague Dr Glenn Lewis, who, until taken far too young by heart disease, was a wonderful supporter. Thank you to the state and territory AMAs for their teamwork. I would like to make special mention of Dr Omar Khorshid, Dr Andrew Miller, Dr David Mountain, Mr Paul Boyatzis and everyone at AMA WA for their support, collegiality and friendship over the past 7 years, or is it 11 years? Who's counting? To the AMA board, so calmly and professionally chaired by Dr Ian Dunlop, I say thank you. To the Federal Council, led with such humility, panache, humour and class by Dr Bev Robotham, I say thank you. To Lauren McDougall, my often barefooted, occasionally sharp-tongued and always capable executive assistant, I say thank you. Thank you to Anne Trimmer for your enduring support and excellence and for the huge reform you delivered in your 5 years as Secretary-General. I wish you the best in the next phase of your brilliant career and look forward to a seamless handover to your successor, Dr Michael Shaper. Thank you to the highly talented and very hard-working Secretariat. Even if you occasionally don't think all these doctors are worth it, you know that your contribution to a better and healthier Australia is. Thank you to the directors in the Secretariat, to Simon Tatz, who only recently left our public health section, and Kate Stockhausen for the fabulous 6 years we spent together on ethics. To Luke Toy, Warwick Huff and John Flannery, I couldn't wish for 3 better blokes or more capable professionals to have guided me through often stormy waters. The credibility you 3 men have within the government and the bureaucracy in Canberra is substantial. It is richly deserved. I thank you. So to the National Conference and the membership, I think that I've delivered on what I came to do, what I said that I would do 2 years ago. We have a better relationship with government. The AMA's job is not to curry favour with those on the Treasury benches, but nor do we necessarily do the bidding of the opposition or the crossbench. We are ferociously, furiously, and I'm sure the senior politicians in the room will agree, often infuriatingly independent. We are getting closer to a better private health insurance system. You've all heard the ideologues who will tell you there's a better way. They are wrong, and the private hospital system must remain a key part of universal healthcare in Australia. In Sweden, citizens buy insurance to move up the public elective surgery waiting list. In Britain, waiting lists extend to many years. Around 90% of Canadians live within an hour's drive of the US border, and trips across it for private healthcare are commonplace. Even the most modestly talented student of history knows how the elites get looked after in Russia and China. No thanks. In Australia, the elites make up 70% of those having surgery. The critics of private medicine are either deluded or willfully misleading. Failure to get PHI reform right is not an option. I care about Aboriginal and Torres Strait Islander Australians. I promise my Indigenous sisters and brothers that my commitment to them doesn't end this Sunday. I care about rural Australia, and I promise the doctors in training action on workforce. Australia doesn't need more medical schools. Australia doesn't need more unimaginative, lazy and morally dubious mass migration programs, importing hundreds of doctors to just end up in our capital cities. The changes we sought to bonding will literally change people's lives. There are the beginnings of real reform. Now it's the time for the states, the territories and the colleges to act. The fact that workforce reform formed the centrepiece of the health budget was no accident. Finally, to my wife Mariam, my daughter Kira and my son, I might get emotional, and my son Patrick for letting me do this job, spending so much time away from home, missing netball, missing football, missing homework, missing dinner. I know it hasn't been easy, but I hope that the three of you and the rest of my family, my mum and dad, Richard and Brad, are proud of what I've achieved. I've done all of this for the little families like ours around Australia who do not have the privilege and therefore the responsibility that doctors have to speak out on behalf of those without a voice, the sick, the aged, the frail, the weak, the poor, the drug-addled, the mentally ill, the unemployed, the vulnerable, the dying. And to the family that is the AMA, I know that and I hope that you think that I've served you well. Thank you. It gives me great pleasure to now introduce the Minister for Health, Greg Hunt. Greg was elected as Federal Member for Flinders in 2001 and served as Parliamentary Secretary in the Howard Government early in his political career. Greg was Shadow Minister in the Environment portfolio between 2007 and 2013 and Minister for the Environment between 2013 and 2016. Greg was appointed Minister for Industry, Innovation and Science in July 2016. And in January 2017, Greg was appointed Minister for Health and Minister for Sport. Greg is serious about sport as a competitor and a fan, and is equally serious about his own fitness. He's chalked up 7 marathons and is known to enjoy the occasional 500-kilometre walk around his electorate for charity. Greg was born and raised on the beautiful Mornington Peninsula in Victoria and lives there today with his wife Paula and 2 young children. He's been an engaging, consultative and approachable health minister and has a deep interest in the portfolio, helped by the fact that both his wife and mother are nurses. Please welcome the Minister for Health, Greg Hunt.
Look, thank you very much to Michael, and congratulations not just on a beautiful and moving speech about the role of the AMA and our doctors, but also on what you've achieved leading the AMA in your time and your period. I'll come back to that in a moment. To everybody here today involved with the AMA, to Tina, who gave such a powerful welcome to country and reminded us and reminded me of the great tasks we still have ahead in dealing with Indigenous health in Australia, to my federal colleague, Catherine King, and to all of those who are simply seeking a very simple goal, and that is better outcomes for patients and better outcomes for those within the health profession around Australia. So let me begin with a simple proposition. I was reflecting yesterday that, in my view, Australia has the best doctors and the best medical workforce in the world. And only recently I was looking at the Commonwealth Fund out of New York's assessment of OECD health systems. Within that assessment, they judged Australia to have the best clinical outcomes of any of the countries. And that's hard data and hard testament to the work of all of those in this room and all of those doctors and nurses and allied health professionals around the country. And that's the basis for my judgment, which is not just anecdotal but backed by international assessment. It said that we have the second best health system in the world, and I think that we can aspire to achieve legitimately the world's best health system as our goal. The missing part is access. That's where we were lower down the rankings. And one of the things that Michael and I have been very focused on is Indigenous health and Indigenous health access. And so as we continue to work forward with the AMA, that will be one of my significant themes over the course of the next year. Now, Michael was right. I think the first call that I made after the Prime Minister gave me a call was to him. There was one difference though. The Prime Minister didn't ask me whom I thought should be the Health Minister of the country. But having been offered what to me is just one of the great privileges in public life to have responsibility for health, I called Michael and we talked about ourselves and each other, but also the great task of building a national partnership between the medical community and the government of the day. And I thought that was an extremely productive start to our working relationship. He finished, though, by putting in a cautionary note. He said, there are two things you have to know about me. One is I'm a working doctor, and two is I'm a West Coast Eagles supporter. And the working doctor was reminded, I was reminded of the working doctor comment looking at the video. During one of our conversations, we'd speak pretty much every week and sometimes once a day, depending on the circumstances. And he would call me or I would call him, and I'd called Michael on this occasion and he said, oh, just hold one sec, I'm with a patient. And I said, no problem. And then the conversation continued. He said, oh, could you just hold on? And I heard the question, so is the baby crowning yet? And I said, Michael, are you okay? He said, yeah, no, the mid's got it all under control. I said, I think you've got a slightly more important and urgent task than talking to me. And he really is a working doctor, as are all of you here, and that's a very important point. On the West Coast Eagles front, he didn't talk about it as much last year, but he does remind me almost every day, every time we speak, that he's a West Coast Eagles supporter, as is my 8-year-old son, whom I love dearly but will miss. And this was presented to me on Sunday night when we spoke as final victory after his West Coast Eagles beat my Richmond Tigers. He felt vindication for his period in the office. But the most important thing we've been able to do is work together to create a partnership. Last year, a year ago, we struck the compact, which was the basis of the contemporary relationship between the government and the AMA. That included $1.5 billion over the period to the end of the current budget of additional investment in Medicare through re-indexation. It included the agreement to work on the MBS reviews, and now more than 90 different recommendations have been adopted by the government for reviewing practice based on the expertise of those who are involved in the profession, and it included an agreement to work together towards the implementation of the My Health record, and that is proceeding. We are moving together with the agreement, all of the states and territories, the AMA and the different colleges, to the opt-out model in the period between mid-July forwards for the next 3 months after that. And by the end of this year, approximately 75% of GP practices are expected to be engaged and enrolled in uplifting data to the My Health Record Service, 75% of hospitals, and I would encourage all of the other specialists in the room to engage in that process as well. Ultimately, it's about the data that can help save and protect lives for patients and to give the clinicians the opportunity to make earlier and better diagnoses. So it's a national tool of national significance which has had bipartisan support, first announced in 2010 and progressed over the course of this decade. It's a major national undertaking. In addition to that work though, we've been able to work together in particular on private health insurance reform, and the changes that were made were about affordability whilst retaining an absolute commitment to the hybrid model of a public system and a private system. And it's only with real structural reform to the cost drivers of that system that we can make it sustainable. But by adding mental health coverage in such a way so as there is no delay for those seeking to upgrade their mental health coverage, improving coverage for rural Australians, and now working towards an absolutely crystal clear system where people will know what's in and what's out of their coverage, then we can put this on a much more stable, long-term basis. So moving forwards from there, what I really want to address is three things today. One is the third wave of reform is contained within the budget. The second is the workforce reforms to which Michael referred that we have cooperated on through multiple discussions, not just with the AMA but with all parts of the medical profession, which will make a profound difference to opportunities for junior doctors, for nurses, for those in medical schools, and therefore to patient outcomes in rural Australia. As Professor Brendan Murphy said to me, the Chief Medical Officer, his view is that this was the most significant workforce reform in 30 years in Australia. And then finally to look to the future, to look at the next steps in relation to primary care and quality outcomes, medical indemnity, and the mental health of doctors and the medical profession. In terms of the budget, the overview is a simple concept. We set out to improve quality and to improve support across all of the different areas of the Australian health and medical sector. All up, there was an addition of $12.4 billion to the health budget in this budget. That takes it to approximately $414 billion over the course of the next 4 years. What it does also is to provide areas of profound reform within workforce, which I've mentioned, within medical research, very, very significant new primary care and other items added under Medicare, new medicines added under the PBS, and mental health initiatives coupled with aged care outcomes. So to look briefly at how we frame this, the long-term national health plan that we've developed jointly over the last year and more is built around the 4 pillars. And the first of those pillars is guaranteeing access to doctors and nurses and medicines through the primary care system and through Medicare and the PBS in particular. The budget added $4.8 billion all up over the course of the next 4 years to Medicare. In particular items, we saw new tests added for cystic fibrosis, for preconception screening, just an incredibly important thing that is part of a much broader plan and practice that we're seeking to introduce over the course of the next decade to give all Australians access to preconception screening. Secondly, we saw new tests added in relation to the capacity for enhanced cataract surgery options, which will help thousands of Australians in rural areas, particularly Indigenous Australians. New MRI screening for prostate cancer, for over 20,000 men who are likely to benefit from that, and new 3D mammogram testing, which will help over 200,000 women in Australia. So these are profoundly important steps forward, which have come out of the work of the Medical Services Advisory Committee and the MBS Task Force, to which so many of you have contributed. Moving forwards, we also see that there was a major addition to the Pharmaceutical Benefit Scheme. One of the most important things that I've been able to do, in addition to working with the AMA on the compact with them and the College of GPs and the pharmacists, was to take steps to put the PBS on a sound basis. Back in 2010, the contingency for new listings was stripped out. That was one of the elements that had a long-term impact on the health budget, not just within medicines, but outside. So dealing with that was in many ways a cornerstone of our ability to do all of the reforms together. Off the back of that, now in this budget we were able to list 1.4 billion of new medicines, and very importantly create an additional $1 billion contingency going forward. And those new medicines included things such as $700 million for advanced and metastatic breast cancer through the listing of Kisqali, a drug that virtually no woman could ever afford, but it's for over 3,000 women it will be profoundly important in its access. Listing of Spinraza, a medicine which would have cost over $367,000 per family for children with spinal muscular atrophy, an impossible ask for virtually every family in Australia. But for them, it will be a life-saving or life-preserving or life-improving drug. And when you meet these families, you understand why your work is so incredibly important. And along with that, a new compact on the life-saving drugs program to increase access and to increase speed under that program to medicines that are exactly that, life-saving. That then brings me to the second pillar of what we're focusing on, which is our hospital system. And that involves the public hospitals, the private hospitals and private health. The steps we've taken to put a foundation under private health after average rises over many years of 6% have led to a 3.95% change. Still too high, but only possible because of sustainable changes which were able to reduce costs in that sector by $1 billion. And that was passed through to the patients, and what we've seen is a 47,000 person increase in private health insurance numbers in the last quarter and a decrease in complaints in the last quarter. So two very important steps. Now it's about ensuring that we have sustainable private hospitals by having that private health insurance, and also we've just now reached agreement with 6 of the 8 states for what will be a $30 billion injection into the public hospital system, and in this budget we'll see public hospital funding climb from 21 to 22 to 23 to $24 billion. So a very, very significant injection of new funds, and Commonwealth funding is increasing at the present period over the last 3 full years of 32%, as opposed to state funding of about 11%. So our investment is significant and growing and fundamental and sustained. Now that brings me to mental health, an issue of immense importance. I know for every single working doctor, for every single family member, whether it's themselves or their patients or their families, this is an issue of fundamental and profound meaning. So in this budget we've built on 3 things in relation to mental health. Firstly, suicide prevention, with support both for Lifeline and significantly expanded services, but in working with Julia Gillard for Beyond Blue and the creation and expansion of the current pilot for aftercare once somebody is discharged from hospital. That's the moment when people are most vulnerable if they have attempted suicide or they have been in hospital for suicidality, and the lack of support subsequently was one of the major surprises to me in coming to this job. So we are dealing with that with a $37 million program, which I hope the states will match, and I'm confident that they will. And that will be about a major investment in working together to provide patients with better support in that period after they've been discharged from hospital. Something that Michael and many of you have championed is a major investment in mental health care within aged care facilities, but also within the community for older Australians. And there's $102 million in that space, and a $125 million medical research Million Minds program to look out over the course of a decade to try to provide up to 1 million Australians with access to treatment which they would otherwise not receive, and access to outcomes which will significantly improve their own mental health journey. That also leads me to the fourth pillar, which is the investment in medical research. Medical research is fundamental to your ability to deliver better outcomes to patients. The medical research budget this year has grown to $6 billion over the course of the next 4 years, and the Medical Research Future Fund has expanded very significantly. So we have a $1.3 billion new program, a health and medical sector growth plan, and that's about the genomics revolution, which will assist with a $500 million investment over the course of the next year to ensure that patients and doctors and researchers are able to see Australia as the global centre for the precision medicine revolution through the use of genomics. $250 million for the Rare Cancers, Rare Diseases program, and additional funding for frontier science research and for the brain cancer mission. So all of these things come together. Perhaps, though, the most significant element was the workforce reform to which Michael referred. That's built around a simple concept of more opportunities for doctors and nurses, and assisting 3,000 additional doctors and 3,000 additional nurses to take up places in rural and regional Australia. The approach that we took together, which was a co-designed program with the AMA and the College of GPs and the College of Rural and Remote Medicine and many other stakeholders, was to build teaching, training and retention incentives. The teaching was where we adopted the Murray-Darling Basin Medical School Network structure, which we'd worked on and agreed upon with the AMA and others, where there would be no new CSPs created. There would be instead the establishment of end-to-end clinical schools right across the Murray-Darling Basin, funds injected into that, as well as new training opportunities for nurses, so people will come from the bush, be able to stay in the bush, and then go on to do their post-medical school training in the bush. Related to that is the Junior Doctors Training Program, and this is about 100 extra places, exactly as Michael was discussing. It's about ensuring that we have incentives through a rural provider number for junior doctors to be able to advance their careers and their training, as well as to provide additional workforce, as well as to have, above all else, better outcomes for rural patients. And then the incentives to recruit and to be increase retention in our rural areas through the Workforce Incentive Program, the Bonded Medical Places Program, which has been reformed, and support for nurses. That's the vision, and that's what we're working on now. And then when you look to the future, let us begin with the notion of improved quality, and that's improved quality in our primary care and improved quality in our hospitals. Fundamental to that is the fact that we've taken the advice of the medical profession, and we are now working with Bruce Robinson, with the AMA, with the College of GPs, on the lessons from the Healthcare Homes program, and advancing that to have an additional focus on a quality structure on an opt-in basis. It's an idea which has 3 partners as a starting point, but the whole of the medical profession, the AMA, the College of GPs and the government, working to create an option for a quality payment framework that general practices may seek to be a part of. And I think that that is a very exciting model that's being developed now and is under consideration. Related to that, though, is wound management. And this is something that's been a personal passion of many of you. I'm delighted to announce today that in relation to wound management, we will, in particular, embark upon a comprehensive program. I am referring wound management to the Medicare task force for consideration. Secondly, there will be $1 million in relation to a wound management pilot program under the primary healthcare system. And thirdly, it will be the first priority of the new health systems translation program under the MRFF. And I think, Michael, that was one thing you were looking for from us before you finished. Further, in regards to medical indemnity, I am delighted to announce today that we will legislate over the coming months to ensure universal coverage and a level playing field. Universal coverage and a level playing field. And then finally, I want to deal with both Indigenous health and mental health. In terms of Indigenous health, one thing that is an unacceptable national shame is the level of transmissible sexual diseases. So the STIs and infections are at an unacceptable level. We will be investing $8 million to ensure that there is a response to the HTLV1 virus that's working with Indigenous communities under the leadership of the Chief Medical Officer and Ken Wyatt. But then that brings us to our own, to the health of our doctors. And our doctors in particular, as Michael acknowledges, are under stress, under challenge, and always facing difficult issues that affect their own mental health. We will continue to work, and I am utterly committed to making to ending the mandatory reporting practice. We have worked together. There are one or two states who still have some issues, but on our watch, in our time, that will become a reality that every doctor who wants and needs help will be able to seek that help without fear. And I think that that is a deep commitment. Thank you. And to back that reality, we will commit $1 million today to support the Doctors Health Services Program, which is overseen by the AMA, $500,000 over each of the next 2 years, so as doctors in rural and remote areas can seek the help when they need it from the people they trust. Ultimately, that wasn't a pause for applause, but thank you. Ultimately, Michael, I want to finish by acknowledging you. At a personal level, you've been a guide, an amanuensis and a friend. I don't think, with the greatest respect, Beverley, a 400 metres runner is the best way to describe him. More a decathlete meets Greco-Roman wrestler. He is skilled at close quarters grappling, and he usually ends up pinning his opponent. But at the end of the day, he's a fine doctor, a fine leader, and above all else, a fine person. Thank you.
All right, the Minister does have another engagement, but he's got time for a couple of questions, and thank you for your announcements today on both Doctors' Health and Indemnity. I didn't fail to make it clear to you that they were important to us and protecting us in our... while we get on looking after our patients, we just need a bit of looking after ourselves, so thank you for those announcements, Minister. All right, it's no secret that the government's healthcare homes trial is in trouble, failing to meet its targeted number of sign-ups and encountering resistance from patients. Will you persevere with the trial, and if so, how do you plan to fix it?
Sure, look, I might respectfully disagree on some of the framing there. At the moment, At the moment, we've got 173 practices. I think that's the last figure that I've got out of a target of 200, so we're building. But this, to me, was always exactly that, a trial. And the model, which is largely, if we're honest, a capitation model, is an interim step. I see this as the basis towards exactly what's being developed now with the MBS task force, where Bruce Robinson said this is a bit different. We need to be able to work with the AMA, the GPs and others towards a quality payment structure for practices to be able to move away from low-value care and have that option, an entirely optional opt-in model, but that's the next evolution of where we're going with healthcare homes. I think we've got valuable lessons from it, but it's not the finishing point. The real point is to move away from low-value care to a quality payment option, so as practices may be able to take that up if they wish.
Well, we've probably just got time for one more question. The pharmacy sector is also an influential health policy body in Canberra. How do you balance their desire for greater access and greater scope to provide healthcare while still restricting the provision of healthcare to those who have the appropriate medical qualifications?
Look, I think all of the different elements of the primary care and healthcare sector have an incredibly important role, and we're blessed with our pharmacy sector and we're blessed with our medical sector. You and I were engaged in a significant debate with some in the pharmacy sector around the upscheduling of Codan. It's quite public that many in that sector did not support that step. I did. I thought it was the right thing to do. Much more importantly, the unanimous view of the medical professionals who were providing advice to the government was that this wasn't just an important step, it was a life-saving step. And I think that it was the right decision, and it was one where we carried it through in the face of opposition. Equally though, I think it's critical that we ensure that prescribing rights are only and ever resulting from the appropriate medical qualifications of our doctors. But there is an important role to ensure where there's not access necessarily immediately to doctors, that there's the follow-up from our chemists, and that's why we have programs such as the dose administration aids. We have the pain meds check and the chronic pain meds check. These are important parts of ensuring that if somebody's visited the doctor, that the patient is given access to advice to continue with the regime. So I see them as complementary roles, even though from time to time there will be disagreements, but fundamentally most doctors and most pharmacists work incredibly well together.
Thank you very much.
Thank you. Yes. Thank you.
Thank you again, Greg, for your presentation today, and it, again, on a personal level, it has been a pleasure dealing with the Minister, always making himself available and acknowledging that delivering the baby comes first, which we all know is how it works. Joining us now is someone who has become a familiar face at the AMA National Conference. I believe this is conference number 4 for Shadow Health Minister Catherine King. She's been here more often than many of you delegates. Catherine was first elected the member for Ballarat in 2001. She too was appointed to parliamentary secretary roles early in her career. She had responsibility for the TGA, food standards and the Organ and Tissue Authority, and became well known to the AMA then. In March 2013, Catherine was elevated to the roles of Minister for Regional Services, Local Communities and Territories and Minister for Road Safety. In July 2013, she was promoted to Cabinet. Then in October 2013, she became Shadow Minister for Health in Bill Shorten's Shadow Cabinet. A keen, lifelong learner, Catherine has a degree in social work and a Master's in Public Policy from ANU, and fairly recently completed a law degree from Deakin University. Catherine King works closely with the AMA, and I'd like you all to welcome her once again to our conference.
Thanks very much for that introduction, Michael, and can I too start by acknowledging the traditional custodians of the land on which we gather, and I pay my respects to their elders past, present and future. To my colleagues, Greg Hunt, I think who's just left us, and Richard D. Natale, who'll be joining you later. It's a privilege to be here. Now, it's rare that something unites both Greg, Richard and I, but as all Richmond Tigers supporters, we're all united against Michael's West Coast Eagles. Unfortunately, not so well on Sunday. I want to thank the AMA for having me at your national conference. I think it actually might be the 5th time I've been here as Shadow Health Minister. I, of course, am hoping to join you in a different capacity at your conference next year. I also want to acknowledge particularly your outgoing President, Michael Gannon, and your outgoing General Secretary, Anne Trimmer. We haven't always agreed, but you have always been very strong advocates for your members and their patients, and I want to thank you for your engagement with me. I want to begin on that point and tell you that the AMA's advocacy does matter. As I travel around the country, I hear frustration about our Parliament and, of course, our politics. And in this room, I know there is frustration about the politics of health in particular. Everyone in the room knows health has been a hotly contested area since the 2014 budget and before. The cuts in that budget and in successive budgets have taken us back to the sort of debate that we saw in the 1970s and the 1980s. And after 4 years of rancour, I know that it is tempting to give up that fight or to settle for the least worst policy option, to hope and to call for bipartisanship in health. But the reality is that the contest in health reflects fundamental philosophical and policy differences between us and the government. These are most stark when it comes to Medicare, our universal public health insurance scheme, and in that context, the AMA advocacy matters. Your members and your patients rely on you to be loud and clear on the issues of the day, and when you are, politicians and policymakers listen. To give you one example, in his budget reply speech this month, Bill Shorten announced our most substantial investment in health so far. In particular, Bill announced that Labor will establish a Better Hospitals Fund and invest an additional $2.8 billion in public hospitals between 2019 to 2025. This investment is a direct response to the AMA 2018 Public Hospital Report Card. The report card has become an important annual reminder of the state of our public hospitals, and this year its edition paints, in the AMA's own words, a pretty bleak picture. The report card reveals bed ratios for older Australians continue to fall and are now at their lowest level on record. Emergency department waiting times have worsened, with up to half of urgent patients not seen within the clinically recommended 30 minutes. And elective surgery waiting times remain too long, with most jurisdictions failing to treat most urgent patients within the recommended 90 days. The AMA highlights that this substandard performance is a direct result of inadequate funding. You say, and I quote, public hospitals continue to face a funding crisis, one that is rapidly eroding their capacity to provide essential services to the public. It's worth reflecting on how that funding crisis has arisen. The last Labor government signed historic national health reform agreements with the states and territories back in 2011. I want to acknowledge particularly Andrew Pesky, Steve Hambleton and the many others in their roles that they played in its development. Under that agreement, the Commonwealth committed to fund an equal share of efficient growth in hospital costs, ending the blame game and giving public hospitals long-term budget certainty. Ahead of the 2013 election, the Liberals promised that they would, and I quote, support the transition to the Commonwealth providing 50% of growth funding. But of course, in the 2014 budget, the government broke this promise and tore up that agreement. And at the time, the government's own Treasury estimated that this move would cut $57 billion from public hospitals. After a fierce campaign from the AMA, and again I want to acknowledge Brian Owler in particular, Malcolm Turnbull restored some of this funding ahead of the 2016 election. But the government is still only funding 45% of efficient growth with a new 6.5% cap on Commonwealth growth. Contrary to the Minister's claims of record funding, the independent experts say that the government's funding formula is not keeping up with public hospital demand. And of course, we are spending more on hospitals in nominal terms. There will be 5 million more people living in Australia in 2025 than there were in 2015. But as the AMA has said itself, the 2016 funding formula is still far short of what is needed. And Macquarie University's Centre for the Health Economy, among others, points out that spending is actually declining on a per capita basis and warned that Australians will either become sicker or be forced to pay more for their medical care. In spite of these warnings, the government is now seeking to lock that funding formula in for another 5 years. Between the next election and 2025, the proposed agreement would mean a $2.8 billion cut from our public hospitals. And as the AMA says, and I again quote, the current funding formula will doom our public hospitals to fail and patients will suffer as a result. That's why Labor will fully reverse the government's cut from 2019 to 2025, meaning an extra $2.8 billion in a Better Hospitals Fund. We will announce more details of the fund in the months ahead, but today I want to give you a sense of our thinking. The Better Hospitals Fund will pay for more activity, more emergency department presentations, more elective surgeries. It will also pay for more resources, beds, doctors, nurses and hospital staff. But we also want the fund to drive innovation in our hospitals. Activity-based funding has made our public hospitals more efficient, and that's a very good thing because it allows more services to be provided within the same budgets. But now we need to work with states and territories to make our hospitals more effective. We don't pay hospitals for what they don't do. There are no financial incentives to prevent avoidable admissions and limited incentives to prevent avoidable readmissions, and we need to create them. 7 years after the National Health Reform Agreements and 5 years after the election of this government, the quality and safety agenda has, in my view, stalled. The government is focused on penalising poor safety, but we also need to think about how we actually reward quality care. The Better Hospitals Fund provides us an opportunity to do just that, and I look forward to working with the AMA on the details of the fund. The 2018 Hospitals Report Card also made a very important point, that hospitals don't exist in isolation and that acute care isn't efficient or effective for all patients. The AMA argues, quite rightly, that coordinated investment in all parts of the healthcare system will deliver better health outcomes at the earliest opportunities, and I couldn't agree more. Labor will have much more to say before the next election about prevention, about primary care and in particular general practice, which is the foundation of our healthcare system, about workforce issues and about the PBS, as well as health inequality, including for Aboriginal and Torres Strait Islanders. But today I want to touch particularly on two priorities, Medicare and private health insurance. First to Medicare. In recent years, thanks in large part to the government's Medicare freeze, out-of-pocket costs have become a significant barrier for many. The Australian Bureau of Statistics tells us that 1 million Australians delay or avoid seeing a GP due to cost, and another 1.7 million are saying that they skip a specialist for the same reason. This means that we are not upholding the promise of Medicare, universal access to healthcare. So we need investment and we need innovation. I'm disappointed that the government didn't take the opportunity of the current budget to end their Medicare freeze immediately and in full. After 4 years, the freeze on GP and specialist consultations will finally be lifted in July. But the freeze will remain in place for specialist procedures and allied health services for another year. Even then, some Medicare items remain frozen, and it's not until July 2020 that we will in fact see the freeze gone, 6 years after it was introduced. And even as the freeze is lifted, we know that the benefits of re-indexation have been marginal. 55 cents on a standard GP consultation, for example. And we also know that the government's freeze will have ripped, by the time it is finished, more than $3 billion out of Medicare, proving that the Minister's claims of record funding to Medicare are simply not true. So we do need new investment in Medicare, particularly in general practice and in broader primary care. Bill Shorten also announced the first of Labor's investments in this in the budget reply, with a significant investment in new MRIs. And everyone in this room knows that access to MRIs is patchy, and many Australians travelling long distance or waiting months to access a machine that is eligible for the Medicare rebate. That's why we announced in the budget in reply 20 new full MRI licences. It's an important process that we'll go through to allocate those licences. Beyond MRIs, we will of course have more to say about more investments in Medicare in the months ahead. As I've said before, we'll also have more to say about innovation in primary care. An older population with higher rates of chronic disease means Australians will need more care and different types of it. Labor's vision for primary care, that is led by GPs but much more integrated with other specialists, allied health and other health providers. We also want much better coordination between primary care and our hospitals. We're not so arrogant as to impose a one-size-fits-all model. We will develop and implement new models of care in close consultation with the AMA and others. And we understand that the government can't keep asking doctors to do more and more with less and less. In general practice in particular, innovation must go hand in hand with investment. It is my firm view that we need to reinvigorate discussion about a vision for general practice, with that discussion led by GPs themselves as well as their patients. So watch this space. Finally, let me turn to private health insurance. Labor has already announced our policy to task the Productivity Commission with an inquiry into the private health insurance system and to cap premium increases at 2% for 2 years. Put simply, we agree with the AMA that private health insurance has reached a tipping point and could enter into a death spiral. Labor wants to maintain private health insurance coverage and the unique balance between our public and our private systems. So we think that the 2-year cap will be an important circuit breaker to private health insurance affordability crisis, but we accept that it is only a short-term measure. We know that our private health system also needs long-term reform to improve affordability and value for consumers. That's why Labor will task the Productivity Commission with the most significant review of the private health insurance system in 20 years, since the Industry Commission's last review. The reality is that in recent years, in recent reviews and reforms, including by the government, we've barely scratched the surface of the complex private health insurance system. In contrast, the last Productivity Commission review led to the modern private health insurance system. Within a few short years of that review, we saw the introduction of important measures like the private health insurance rebate and the lifelong health cover loading. We should be no less ambitious for this review, and I look forward to working on that with the AMA. In conclusion, I do want to leave time to take questions, and I'm very happy to take those questions from the floor. I know I've been given some on notice, but I'm very happy to open that up to the room. Regardless of who is in government, your members and more importantly, the patients that you care for, need the AMA to fight for universal access to world-class healthcare for all Australians. And I look forward to working with you on that aim and the lead up into the next election and beyond, which I suspect is going to be a little bit sooner rather than later. Thank you very much for having me here this morning. Thanks, Mark.
Look, we don't have too much time for questions, but I will ask one, and if someone wants to go to one of the microphones, there might be time for a couple more. Catherine, you referred to the Productivity Commission review, which we support, and we support your engagement on the issue of private health insurance. Health inflation runs at about 5%, PHI premium growth runs at 5%, and historically sometimes more than that. How will the 2% cap work, and how will you avoid insurers, how will you avoid the small insurers going to the wall? How will you avoid the consolidation in the industry, which might lead to more corporate behaviour, because it's the smaller mutuals that are probably the most marginal? And how will you avoid the insurers just doing an even larger catch-up increase when the cap is lifted?
Sure. Thanks, Michael. Well, we thought pretty long and hard about the policy. It didn't come from nowhere. We do get lots of information still from people who have worked in APRA, so we thought the 2% cap was a good circuit breaker. What we've also said is we'll work both with APRA in relation to small insurers to ensure that there's not a negative impact on them, and the ACCC in terms of some of the behaviour we may be likely to see, which we're already seeing, frankly, with Bupa just more recently from the private health insurers. But the most important part of it is going to be the Productivity Commission. I think that's the point that John Howard missed when I think he capped private health insurance at 0% for 1 year, and then there was a very substantial catch-up in that last year. It's that reform journey that's going to be very important. We've got a small issues paper that'll be coming out shortly. We'll be consulting on the terms of reference. The Productivity Commission, I think, is pretty hot to trot on this sector. It's not something that's been looked at for the last 20 years, and that part is going to be pretty crucial, alongside some of the reforms continuing that the government has already started, which we've acknowledged. You want to ask me a question?
Dr. Gino Pecoraro.
Thank you very much. There's every chance that you're going to be our next health minister after the election.
Thanks for the vote of confidence, Gina.
I said every chance. Can you tell me where you would stand? We're looking at having a grading of private health insurance policies with bronze, silver and gold and other. And yet, nothing we've heard so far will give succour or comfort to the greater than 50% of Australians who are female and their families who can get pregnant. Less than 50% of pregnancies in Australia are planned. That means that most of them could be considered accidents. Will you promise and commit today to make sure that pregnancy is included in the entry-level private insurance products?
I think you might have asked me this question last year as well.
Every year.
I'm pretty sure you did. The first thing is that we haven't seen, and obviously the AMA has been involved, as have the private health insurers, with the government, so we haven't seen the final what's in or out, so we don't know yet. So the first thing is we need to have a look at it when the government announces it. We still think there is this very substantial issue around junk policies. We do think there is still that. We have announced that we won't be paying the 30% rebate on those. If the insurers want to continue to have those, then that's up to them. But our view is that we shouldn't do that. So it's a bit difficult for me to say what we do because we don't know what's in or out yet. What we have committed to in our national platform, it looks like, unfortunately, as a result of yesterday, our national conference is likely to be substantially delayed because the government has somehow decided the only possible date for the 5 by-elections is on the exact same date as our national conference. But in that, there's a substantial rewrite of the Reproductive and Sexual Health chapter, and one of the significant issues I think that we've got to do is actually have a long-term reproductive health strategy in this country where we actually do start to look at what is happening for women and for access to maternal and maternity services across this country. But thank you for the question again.
One last question, Dr. Robert Parker.
Catherine, the Minister referred to the current STI epidemic in Central Australia, which I think the government's having significant problems dealing with. And you're probably aware of my communication with the Minister about a need for a National Centre for Disease Control. And the AMA's produced obviously a position statement supporting that. Have you got any concept of what an incoming Labor government might do in respect to enhancing disease control in Australia?
Well, I think the first thing we wouldn't have done is cut substantial amounts of funding out of sexual health clinics for Aboriginal and Torres Strait Islanders. And that's the reality of what they have actually done. And the fact that we haven't actually had the funding that is needed to drive some of the services in those communities has been really, really significant. And I think we are behind where we should be because of those decisions that a government has taken. I've had a number of representations about a CDC. I'm having a think about it. The issue for me really is about where is the capacity missing currently in this country in terms of emerging and infectious diseases? How do we actually ensure that capacity? When I worked in the Department of Health, the environmental health section, they were a pretty skilled group of people, but not really connect. There was a lot of disconnect between some of the work being done in states and territories. So I'm having a think about what that capacity might be, whether it's a CDC or not. I'm not 100% convinced about that argument yet, but that's being honest. Thanks.
Thank you.
Can you please all thank Catherine King?
Good luck on your last 48 hours.
Thank you.
And here? Right. Lovely, thank you. Got a collection of these now. I have. That's all right, my pleasure. Thanks.
And I'd also like to pass on my personal thanks to Catherine for her engagement and availability to speak and to listen to the arguments of the AMA. So Thank you, Catherine. I now welcome the Leader of the Australian Greens, Senator Richard Di Natale, also known as Dr Di Natale, and also an AMA member along the way. Dr Richard Di Natale is Leader of the Australian Greens, Senator for Victoria and Greens spokesperson on health, sport and multiculturalism. The son of Italian migrants, Richard grew up in Melbourne and now lives on an off-grid working farm in the foothills of Victoria's Otway Ranges with his wife Lucy and their 2 young sons. Prior to entering the Parliament, Richard was a VFA footballer, a general practitioner and a public health specialist. He worked in Aboriginal health in the Northern Territory, on HIV prevention in India and as a drug and alcohol clinician in regional Victoria. Richard was elected as the Greens' first Senator for Victoria in 2010 and became the 3rd leader of the party when Christine Milne stepped down in May 2015. He is the co-convener of the Parliamentary Group for Drug Policy and Law Reform, the Parliamentary Friends of West Papua and the Parliamentary Friends of Medicine. The AMA has a positive working relationship with Senator Di Natale on a range of issues. I'm told Richard makes a mean pizza, grows and bottles his own wine, and now, maybe still now, a very proud Richmond Tigers fan after many years of wandering and suffering. Please welcome Senator Richard Di Natale. Coming up there.
Thank you for that very expansive introduction. Let me begin by acknowledging the Ngunnawal people as the traditional owners of the land on which we meet. I want to recognise specifically that the burden of illness in Australia falls disproportionately on our First Nations Australians, and it's a huge challenge it's incumbent on all of us to address. Let me also acknowledge the Minister of Health, the Honourable Greg Hunt, the Honourable Catherine King, Shadow Minister for Health, outgoing AMA President Dr Michael Gannon, Vice President Dr Tony Bartoni, AMA Federal Council Chair Dr Beverly Robotham, and of course all of you as AMA National Conference delegates. It's a great pleasure to be here. We are on the precipice of a federal election. I heard from Catherine that she thinks it's going to be sooner rather than later. I think it's anyone's guess, but look, it's a matter of months away, whatever the Prime Minister decides. And despite the fact that health's going to be at the top of voters' minds, it seems that it's an area that the government is determined not to talk about. We've had 6 years of coalition government. The focus in health seems to have been on cost cutting, and it's meant that the whole of the sector, from GPs to specialists, allied health professionals, we're fighting for our very existence. We're fighting often battles that we thought we'd already won. I mean, we all know that general practice is the heart of our health system, and yet we're fighting to value it. We know that Medicare is a very effective way of funding our health system, and yet again we're fighting cuts to Medicare. We know that our public hospitals are already under significant strain, and yet we're fighting to stop patients languishing on waiting lists for months and years. And we're having those fights in the midst of what appears to be an election that's shaping up to be fought on the issue of tax cuts. Being frank, I worry that regardless of who wins government, we're in for more of the same, because every dollar that's given away in this pre-election bidding war on tax cuts is a dollar that can't be invested in our health system. It's a dollar that can't be invested in Medicare and in our hospitals. As a leader of the Greens, we've got a very different vision for our health sector. It starts with funding it, and we fund it through a progressive taxation system. We fund it through progressive taxation because we know that that is critical, firstly, if we're to have a well-funded health system along with other essential services, but also progressive taxation is one of the most important weapons to fight inequality. We also understand very deeply the impact of social and environmental impact factors on people's health. They're the strongest drivers of health. And that's why we're committed to fighting inequality and to ensuring we've got a cleaner, more sustainable economy. And of course that means tackling climate change. When it comes to the health system, I see health as an investment, not a cost. I see it as an investment in our people, in our society. Our vision for health is one where our health system is universal. It's universal and it's focused on prevention. Prevention is at the very heart of any efficient health system. It's a vision for a health system that addresses a lot of the long-term challenges that we face. We've got an ageing population, a burden of chronic illness. We need to set up our health system not just for next year and the year after, but for the next decade and the decades beyond. And when it comes to each and every one of those measures, we're currently failing. We are failing and failing dismally. We've got more and more Australians now living with chronic illness due to poor diets and lack of exercise, and we know that today that's influenced both by your income and where you live. About half of Australians have at least one chronic disease, 1 in 5 have multiple, and a third of Australians are now obese. Look, it doesn't matter how many op-eds the CEO of Coke wants to write for The Australian. The reality is that we know that lack of exercise is not the central issue, and the facts simply demonstrate that. Rates of physical activity have stayed reasonably steady over time, and what's changed is the consumption of high-calorie and low or no nutritional foods. What's changed is the aggressive marketing of processed sugar-laden foods, and of course what's changed is the fact that we have both the Labor and Liberal Party who receive those massive donations from the junk food industry so that they have a seat at the table. The problem is they no longer have a seat at the table, they now own the table and they're preparing our meals. We've got a problem with alcohol in this country. In Australia, alcohol has been found to account for nearly 5% of the burden of disease. It has a huge impact on individuals and our community. You know the litany of problems: physical violence, cirrhosis, psychosis. It's responsible for so many harms, yet treatment's chronically underfunded, advertising's rife, and of course the government's only intervention in this area in recent times has been to make beer cheaper. We've got a problem with illicit drugs. We know that millions of Australians use illicit drugs, and instead of treating that as a health issue, we criminalise them and we put people at greater harm. We know that too many Australians still smoke, and despite everything that we know about the harms, that continues to happen. We've seen smoking rates plateau over time. There's been some good moves in this area over a number of years, but we can't afford to be complacent. The bottom line is that despite all of these challenges that we have, the government has no plan for prevention, no investment in genuine prevention. They dismantled the Preventative Health Agency. They gutted flexible funds, which were responsible for delivering health promotion on the ground in communities. Healthcare homes, which was spruiked as transformative for millions of Australians with chronic diseases, has all but been abandoned. And of course, it makes no sense. It makes no sense economically or socially. Preventative health improves people's lives. It saves money in the long run. We know that we're throwing a lot of money at acute care, but there'll always be waste if we're not preventing people from getting sick. And just need to look at what the Grattan Institute found. Avoidable hospitalisations due to chronic illness cost our system about $320 million each year. We can change that. So why isn't it happening? Well, we know that this is a long-term investment, and politicians don't think long-term, they think in terms of electoral cycles. We know that people who are saved from having a heart attack or a stroke aren't as noisy because they don't know they've had a benefit as somebody who's waited for an afternoon, a day, sometimes 2 days in an emergency department. And it's also happening because both sides of politics are captive to donors who make huge donations through what I believe is state-sanctioned corruption. That's our political donation system. So it is our role, and this is what the Greens believe, it's what I believe, to ensure that we have a society that promotes illness and prevents people from getting sick, and there is a role for active government intervention in this space. It starts by addressing the social and environmental determinants of health. As I said earlier, the debate around tax is also a debate around health because it goes to the heart of inequality in Australia. The debate about New Start, where we are condemning people to living a life of poverty, is also a health issue. When it comes to climate change, we know that the impact will be felt disproportionately on the vulnerable, on older people, on children. This is also a health issue as much as it is an economic one. We need to transform our primary care system. We need to improve chronic disease management. Medicare has to be improved in the way we deliver services. It has to be funded. We need to make better use of the skills in a range of health professions, including allied health, and there has to be better recognition of the role of GPs in integrating this care. I've just established the Senate Committee on the Obesity Epidemic, and I did it in response to universal calls for action. Look, I urge all of you, as doctors, as members of professional bodies, as members of the AMA, to make a submission into what we can do around this significant public health issue. The Greens' policy is to ban alcohol advertising during the times the kids watch TV. At the moment, a young person can watch a sporting broadcast in the middle of the day and be bombarded with alcohol ads. We want to clamp down on promotion, and we want a much more rational taxation system when it comes to alcohol. At the moment, the taxation of alcohol is a dog's breakfast. We want to have a system where tax reflects the amount of alcohol in a product, moving towards a volumetric system. Our plan for illicit drugs is clear. We want to treat illicit drug use as a health issue, not as a law and order issue, and that's on the basis of evidence, following the evidence. We've just announced our policy to tax and regulate cannabis. This is a health policy to reduce harm. Don't take my word for it. Take the word of that hippie radical journal, the British Medical Journal, whose editor-in-chief published just this month a piece in favour of taxing and regulating drugs. As Fiona Godley writes, this is not about whether you think drugs are good or bad. It's an evidence-based position entirely in line with the public health approach to violent crime. We've got to get much smarter about the way we finance healthcare. Look, we've got some good news on that front. Australia does pretty well. We spend about 10% of our GDP on healthcare. That's close to OECD average. In most European countries, it's slightly higher. In the States, it's almost double. And of course, they get much worse bang for their buck. You see, when you believe spending on healthcare is an investment, not a cost, when you think it's a dividend of a society progressing, developing, having an economy that delivers more for people, you actually start to see healthcare in a very different way. I just think it's remarkable that we have a public debate in this country that sets nominal targets for how much we should be spending on defence. We need to up our spending on defence to reach a nominal target, and yet in healthcare, we're saying we need to reduce the amount we spend on healthcare. It's just a question of priorities. We know that when it comes to funding our health system, cost shifting is a huge problem. The state-federal divide, I'm sure it drives many of you nuts in this room. It's again a dog's breakfast of divided responsibilities. It leaves the system vulnerable. When we saw that dreadful 2014 coalition budget with Tony Abbott at the helm, we saw the funding for federal hospitals slashed and effectively ripped up the agreement that was at least doing something to ensure that we had a more rational basis for allocating funding. Well, our solution to that is we should be restoring the 50-50 funding agreement, and we should also consider legislating for it so that future governments can't take it apart. But that's not a long-term solution. Long-term, our view is that there has to be a single independent funding agency for healthcare. Try and get the politics out of it, try and ensure that we've got a much more rational basis for funding our health system, not the whim of the government of the day. And if this government's taught us anything, it's that the funding for healthcare is not safe under the current system. We believe that Medicare, which is effectively a universal insurer, is essential to be able to provide universal healthcare. But we know despite the fact that we thought it was so popular with the Australian community that no government would touch it, that we've seen a freeze on Medicare indexation. It must be said it was started by the Labor Party when they were in government. And of course, the current government took the freeze into an ice age, and only recently have they announced that it's coming off, but far too slowly. And we all know it would be in place if not for the strong advocacy of people in this room, the AMA, the College of General Practice and many others who fought tooth and nail to see that change. Our policy is to ensure that we have an immediate removal of the freeze across all items, including diagnostic imaging. We acknowledge that there's also inefficiency in the system, and we have been strong advocates for ensuring that we fund MBS items based on evidence and work with the profession to cease funding of low-value items. In fact, when Susan Lee at the time became Health Minister, I offered a support for any initiatives in this area. And clinician-led evaluation of practices, it is an essential part of the renewal of our system, but it can't be a cost-cutting exercise. Every cent needs to be reinvested back into the health system. When it comes to private health insurance, the industry is in crisis right now. Premiums are going up, patients are getting less and less, and exclusions are growing. Complaints about private health insurers are piling up. We've heard that time and time again through Senate estimates. Now, the recent reforms that have been announced are some baby steps in this area, but they don't deal with the central problem. And the central problem we have is that the private health insurance rebate in our system is inflationary, it's inefficient, and it is unfair. The Greens want to reinvest every cent back into public health to ensure we preserve our universal health system. We acknowledge that people will continue to take out private health cover if they wish. It's an important part of the system, but let us not confuse the private health insurance industry and the important work that good doctors do in private hospitals within the private setting. And of course, we need to uncouple those two things. The recent inquiry into private health insurance highlighted that transparency was an issue. People described something called bill shock as a key issue for private health insurance policyholders. So that's something that needs work, and obviously that's a discussion that needs to continue with the profession. Let me finish by acknowledging again the critical role that the AMA plays in the national conversation around healthcare. You operate at the highest levels of political advocacy in this country. You do a very important job. Doctors are some of our strongest advocates for broader social issues, and it's my view that the AMA is best when it's more than just a professional association of doctors advocating for their own self-interest. Right around the country at the moment, we have doctors calling out the brutality of our refugee detention policies, Doctors for Refugees, the Australian Medical Students Association, and many others. There are many individual doctors who do incredible work forcefully advocating for change, and I want to wholeheartedly congratulate them for it. We've got wonderful doctors advocating for action on climate change, Doctors for the Environment, the Climate and Health Alliance, the College of Physicians, who have done remarkable work in this area. I recently met with David Pension from the NHS Sustainability Unit about the amazing work they're doing in the UK, and was really inspired by what doctors are doing there in making action happen. Now, I know the AMA is shortly going to have a new president, and I do hope that they'll once again stand behind these inspirational doctors and take up the mantle on all of these important issues. I hope the next president returns the AMA to advocating for the health of refugees locked up in offshore prisons. Innocent people who are experiencing serious health impacts from both indefinite detention and the withdrawal of medical services. I hope the AMA will once again advocate for a serious response to climate change, including the rapid phase-out of polluting coal-fired power, because both climate change and coal-fired power have catastrophic impacts, not just on all of us, but on the generations that follow us. I hope they'll play a constructive role in debates on other important issues like voluntary assisted dying, rather than denigrating the experience of those who advocate for change. It is part of our mission as health practitioners that we step up and advocate not just for our profession, but for the health of all those individuals and the community that we serve. And we need to do that no matter who we might upset in the process. Thank you, and I'm happy to take some questions.
Thank you, Richard. The Greens have a strong view on the value of private health insurance, namely that it's not worth it. Do you see the private hospital system, the private practitioners in that system, as taking a burden off the public system? And if we don't have affordable private health insurance to make the private system viable, what is the alternative?
I think, as I said in my speech, it's really important to uncouple private health insurance from the doctors who are working within the private system and private hospitals. At the moment, we've got a financing problem where we've got a private health insurance, and you don't have to take my word for it. People are voting with their wallets. They're not seeing value in the product. Premiums are going up, the list of exclusions are going up, and people see they're not getting the value for money out of that product. We've got a $6.5 billion annual subsidy that goes from people who don't have private health insurance to people who do. That's inequitable. And that policy is inflationary. Imagine being a business where the government underwrites 1/3 the cost of your product. You know that every time you increase the cost of your product, the government is going to be underwriting 1/3 the cost of that product. It is an inflationary system. So what we need to do is we need to uncouple the private health insurance industry and the services that it provides from the services that doctors who are working within the private system and private hospitals. And that means a more, again, active role for government for commissioning services directly through private hospitals, and we're looking at what some of those options look like. Private health will always be an important part of the Australian healthcare landscape. We know that a significant proportion of our hospitals and medical staff who work in the system work in the private system, and we need to ensure that we have a model to fund them that is sustainable. And anybody who argues that the status quo around private health insurance is sustainable is kidding themselves. We are going to see change in this space. The question is, what does it look like?
I think we've got time for 2 questions from the floor.
G'day, Richard. I'm Wayne Hurdy. I'm from the Sunshine Coast. I work in the dirty end of medicine. About 1/3 of my practice is in addiction medicine. You're the first person today to have referred to illicit drugs, and you obliquely referred to the ice epidemic. About 4 or 5 years ago, Susan Ley, when she was the Minister for Health, she committed a huge sum of money for the treatment of hepatitis C because she was told that the hepatitis C epidemic and hepatocellular carcinoma was going to bankrupt the country if she didn't fix hepatitis C. Sometime somebody in Canberra is going to realise that the ice epidemic is going to bankrupt this country if we don't do something about it. So far, I only see the government paying lip service to the management of illicit drugs, of which ice is the tip of a very big iceberg. I know of about 200 GPs in the entire country who treat drug addicts, and what are you going to do to make sure that the government, because unfortunately you're never going to be in government, but what are you going to do to make sure that the government actually does something about this?
Never say never, but I acknowledge it's unlikely to happen at the next election. I mean, you just need to look at what people do before they get into politics to have a sort of sense of what their interests and where their passions are. And I worked as a drug and alcohol doctor, and I just think it's remarkable that we live at the moment in a modern, prosperous country like Australia, and yet we can still treat people who have a problem with substance dependence right on the margins of society, marginalise them, stigmatise them. It's one of the few areas where we haven't made the sort of progress that we've made in so many other areas. I firmly believe it's a health issue, not a law and order issue. The first thing we need to do is we need to remove criminal penalties for people who engage in personal drug use. It doesn't work. I know that's an AMA position, so I'm pleased to hear that the AMA have that view when it comes to substances like cannabis. It doesn't work. It just serves to divert resources away from where they're needed, and it means that we give young people a criminal record, jeopardise their prospects of employment and a range of other things. So the first thing is, let's adopt what Portugal did and remove criminal penalties for personal drug use. Let's redirect the money we're spending towards law enforcement for individuals who are substance dependent to treatment. There is no excuse for people in Australia having to wait for 6 months and longer to get treatment when they have a problem with an illicit substance. And I'm sure, that's a frustration you felt very acutely. So we have to fund treatment adequately, and we have to fund treatment on the basis of the best available evidence, and there's a role for ensuring there's tighter regulation so that what's being delivered actually works. We need to look at the argument for the taxing and regulating of substances that at the moment, like cannabis, are widely consumed and divert so many resources away from where they're needed. And we do that within a health framework so that we regulate for less harmful substances and take it away from criminals and syndicates who are the only ones who benefit. We are always going to, my view is, I think Australia, right around the world, there will be people who continue to consume illicit drugs. Our role is to provide the treatment for those individuals who consume them and develop a problem, and to do it within a health framework.
Rob Parker from Darwin. I mean, my work is mainly treating Indigenous Australians who suffer from psychosis, a lot of it relating to substance abuse. I recently sent you the copy of the article by Starza, a very good condition study showing the relationship between cannabis and later severe mental illness. Has that altered your views in any way in respect to the legalisation of cannabis?
Has the BMJ editorial altered yours?
I'm probably more concerned about severe mental illness because that's what I deal with. And again, the fact that Aboriginal Australians have 4 times the rate of psychosis.
So that's happening right now. That's happening now. It's happening under the current system. My view is, the definition of insanity. Just keep doing what you're doing and expect it's going to improve. So I'm with the evidence here. The BMJ have taken a very strong view that they believe the taxing and regulating of substances is a way of reducing harm, not increasing them. What we can do is we can ensure that we regulate for those products that are less harmful than the ones that are currently being consumed. We can ensure that every individual who gets this isn't getting it from a criminal who wants to sell a more harmful, more profitable, riskier product, but is in the hands of a professional who can provide advice, who can provide referral pathways to well-funded treatment services so that somebody who is developing a problem is identified early, is referred and gets treatment. That's the system I think is, and again, I'm not on my own here. We've got a wealth of medical evidence behind us to support the position as evidenced by the BMJ editorial. Thank you. Thanks very much.
Thank you very much, Richard, for challenging us again. I started today's proceedings by welcoming a great number of ex-presidents to the room. It's 25 years since I first sat on the Federal Council of the AMA as the AMSA president. The AMSA president was invited to sit on Federal Council by Dr. Bruce Shepherd. Sadly, we lost Bruce today. Bruce was a giant of our profession. Bruce was a giant of the AMA. I look down on a couple of giants here right now in Mukesh Haikawal and Bill Glasson right in front of me, and yet Bruce casts a shadow across all of us. His leadership was unequalled. His portrait still sits in the boardroom at AMA House. It was Bruce who brought us to Canberra. It was Bruce who got the doctors in training a seat on Federal Council. It was Bruce who got the medical students a seat on Federal Council. He led us in so many ways. Bruce, after a long battle with illness, passed away at 7:30 this morning. I think it's appropriate if we just observe a moment of silence for our colleague, Dr. Bruce Shepherd. Thank you all very much. One of the great joys of being AMA President is you get to sit on a number of selection panels for important awards. Ladies and gentlemen, the AMA National Conference would not be the National Conference without awards, and we have a couple of important ones to present now. The AMA Excellence in Healthcare Award is an award for a recipient so distinguished that even just settling on the wording of her citation took the Secretariat hours. The AMA Excellence in Healthcare Award is for an individual, not necessarily a doctor or AMA member, who has made a significant contribution to improving health or healthcare in Australia. The person may be involved in health awareness, health policy or health delivery. Professor Elizabeth Elliott AM certainly fits all those criteria. Professor Elliott is a pioneer in research, clinical care and advocacy for fetal alcohol spectrum disorder and has been a passionate advocate for raising awareness of FASD for more than 20 years. FASD, which is caused by prenatal alcohol exposure, is now recognised as the leading preventable cause of prenatal brain injury, birth defects and developmental and learning disability worldwide, with lifelong consequences for children and their families. FASD prevalence has been estimated at 5% in mainstream communities, 20% in some remote Indigenous communities, and in 36% in young offenders in Western Australia. Until recently, there were no diagnostic guidelines, limited clinician skills, and no specialised clinics. Professor Elliott played a significant leadership role in developing the Australian Guide to the Diagnosis of FASD, online training modules, new clinical services, a national FASD website and a national FASD register. She was nominated for this award by the National Organisation for Fetal Alcohol Spectrum Disorder, No FASD, the first and largest organisation dedicated to the cause in Australia. Over the past 20 years, FASD has evolved from being a little known, poorly recognised and misunderstood condition to becoming a major strategic focus for Commonwealth and state health departments. Professor Elliott is a true pioneer in the FASD field and has contributed to the development of Australia's response to FASD through addressing aspects of health policy, healthcare delivery, education and health awareness in the work she's undertaken. However, FASD is only one component of Professor Elliott's work, which includes disadvantaged children in immigration detention, those with rare disorders and those living in remote Australia. In 2008, she was made a member of the Order of Australia for services to paediatrics and child health. In 2017, she received the Howard Williams Medal from the Royal Australasian College of Physicians, its highest award for her contribution to paediatrics in Australia and New Zealand. Much of her work has been undertaken voluntarily and has strengthened Australia's health systems and their capacity to respond to FASD. Her efforts have improved healthcare services in FASD and changed health outcomes for children and families living with and affected by the disorder. She is a worthy recipient of the AMA Excellence in Healthcare Award. Please welcome her to the stage. I'd like to call on Professor Elliott to say a few words.
Well, thank you very much, Dr. Gannon, for your kind words, and I too acknowledge the traditional owners of the land on which we meet and pay my respects to all Aboriginal people here today. I'm both humbled and delighted to receive this award, which I accept on behalf of all of the children and clinicians with whom I work. As Michael said, I was nominated by the National Organisation for Fetal Alcohol Spectrum Disorders, and I paid tribute to their CEO, Louise Gray, and the founder, Sue Myers, who worked tirelessly to advocate for improved services and to support families living with FASD. My own journey in FASD began about 40 years ago as a paediatric trainee when I saw these children at the Children's Hospital. And for the next 20 years, it fell off my radar. Indeed, up until 2000, there were only 5 publications on FASD in Australia. That year, Professor Carol Bauer and I set up a national surveillance system, and we had 100 reports of cases from paediatricians. So, for the next 20 years, we've explored the prevalence of fetal alcohol spectrum disorder and alcohol use in pregnancy, knowledge and attitudes of health professionals and women regarding alcohol use in pregnancy and FASD. And we found that doctors don't ask about alcohol use in pregnancy. They don't know how to ask and they don't know what to advise. We found that they don't know how to diagnose FASD or where to refer, and that they're afraid of stigmatising women and children. In 2009, my journey took me to the remote Fitzroy Valley in the Kimberley region of Western Australia at the invitation of Aboriginal leaders June Oscar and Maureen Carter. These courageous women had fought hard for alcohol restrictions, and they now wanted to know what was the effect of alcohol in pregnancy. Few of you, I imagine, will have visited towns like Wonkajonka, Nunkanbar and Bayulu. Few will have heard the languages of the Wallamajori, Gooniyandi and Bunaba people, and few would comprehend the extreme disadvantage in which so many of our remote Aboriginal people live, and which really is underpinning alcohol misuse. Nearly 20% of the children that we assessed had FASD with consequent learning, behavioural and developmental problems. But with wonderful Aboriginal friends and colleagues, we continue to support these families. But FASD is not an Indigenous problem. In our recent pregnancy cohorts in Victoria and New South Wales, about 60% of non-Indigenous women told us that they drink alcohol during pregnancy, many before pregnancy recognition, and in ignorance of the potential harms to the unborn child. And in my FASD clinic in Sydney, I rarely see Aboriginal children, but many children in foster care, out-of-home care, child protection and juvenile justice. So in 20 years we've made great gains, but we have a long way to go. We've had great support from Australian and state governments, the NHMRC and NGOs such as No FASD and the Foundation for Alcohol Research and Education. But we have a long way to go, and you all have a role to play through awareness raising and advocacy. I thank you for honouring my work today, and I look forward to a future that includes early diagnosis, effective treatment, but above all, prevention of the tragedy of FASD. Thank you.
Congratulations, Professor Elliott, a very, very worthy winner. And now to the second of our awards and the last before we break for lunch. The AMA Woman in Medicine Award is presented to a woman who has made a major contribution to the medical profession by showing ongoing commitment to quality care or through her contribution to medical research, public health projects, or improving the availability and accessibility of medical education and medical training for women. This year's recipient is someone who has made a major difference to the lives of countless thousands of women in third world countries living with the misery of preventable gynecological trauma. Professor Judith Go AO is a dedicated gynaecologist who volunteers her time treating women in war zones and third world countries. For the past 23 years, Professor Goh, a world-renowned surgeon, has spent approximately 3 months each year training doctors in third world countries in repairing vesicovaginal fistula, a devastating injury that can occur following prolonged obstructed labour. Professor Goh's nominators, colleagues from the Australian Federation of Medical Women and the Queensland Medical Women's Society, have described her career as both humbling and inspirational. Since 1995, Professor Goh has donated her time and expertise, working abroad several times a year as a volunteer fistula surgeon in many parts of Africa and Asia, including Bangladesh, Sierra Leone, Ethiopia, Tanzania, Uganda, the Democratic Republic of Congo and Liberia. Professor Goh runs the twin projects, medical training in Africa and medical training in Asia via the charity Health and Development Aid Abroad, HARDA, using funds raised to help pay for women's surgeries such as the correction of genital tract fistulae and prolapse while training the local staff in these areas. To carry out her work within a dedicated team of professionals, Professor Goh often has to brave political unrest and perform surgery in challenging environments, as well as deal with the emotional and social injuries to her patients due to war, rape, domestic violence, poverty, shame and grief. Her work has changed lives for the better for hundreds of affected women, correcting their often long-standing and preventable obstetric trauma, including vesicovaginal and rectovaginal fistulae. Professor Goh uses her time abroad to upskill local practitioners in this area of medicine and to raise awareness of the underlying causes of chronic complications of birth trauma, including poverty, lack of education, lack of awareness, and the subordination of women in some cultures. In 2012, she was made an Officer of the Order of Australia for distinguished service to gynaecological medicine, particularly in the area of fistula surgery, and to the promotion of the rights of women and children in developing countries. Her humble dedication within this field of women's medicine and her brave and generous service to women all over the world is inspirational, and she is a very worthy winner and very worthy recipient of the AMA Woman in Medicine Award. I'd like you all to please welcome Professor Judith Goh to the stage. Congratulations. I'd like to invite Professor Goh to say a few words.
Thank you. Thank you, Dr. Gannon. Thank you, everyone, for a very warm reception. I'd like to thank my nominees for obviously nominating me, but to thank the AMA firstly just for considering my nomination, and then thank you very much for presenting me with the award. When I teach, whether it's here in Australia or whether it's in some low-income, low-resource area, one of the first things I say is to my students is that the most important person in the room, whether it's in the outpatient clinic or whether it's in theatre, is the patient. It's all about the patient, it's all about the woman, a gynecologist, so it's all about the woman. And we're all there for her. So in this award, I'd like to highlight the plight of women's health, maternal health around the world. In some places, 1 in 6 women will die, will have a lifetime risk of dying because of childbirth and pregnancy. So that's phenomenal. Plus, women also suffer great injuries, such as the obstetric fistula. So some of the patients that I see, all they want to do is to survive the pregnancy and childbirth. We also know that education of girls, literacy and just even primary education has a significant impact on maternal mortality and morbidity. In accepting and receiving this award, I'd like to thank the women that I've had the opportunity to treat, and I'd like to thank them for the privilege of serving them. Thank you.
Congratulations again to both our award winners. I'm sure you'll agree, very, very worthy.
Well, thank you for that. One of the obligations that I have as Secretary-General over this weekend is to try and balance proceedings with delegate briefings and allowing our delegates, our candidates for election to have the opportunity to speak with those delegates who will be voting for them on Sunday morning. So given that we're running a little bit behind time, I don't want to cut short those opportunities over lunchtime. What I'm proposing to do is to take a little bit of time off afternoon tea, which means I think we're about 10 minutes late, maybe 15 minutes. So lunchtime and the briefings will go a quarter hour longer than lunchtime was otherwise scheduled, because there will just not be an opportunity for those who are scheduled for this lunchtime to hear from all of the candidates. A couple of other things to remind you about. Any urgency motions need to be notified by 1 o'clock, so could you please ensure that Lauren has those before 1. Lunch will be in the Eureka room, so you go down to the ground floor and out to the back of the hotel. That's where the Eureka room is found. But could you perhaps give priority for those getting their lunch to delegates from WA, Tasmania and Queensland, because they are the delegates who are going to hear from candidates over lunchtime. So rather than bottleneck them in long queues, if you could give them priority to have their lunch quickly before going to their rooms. Now, in terms of the rooms, the West Australian delegates, so when I talk about delegates in the context of the elections, it's the delegates with the dark blue lanyards, and I'll explain the other coloured lanyards later, but the dark blue lanyards are the appointed delegates who will be voting on Sunday morning. The West Australian appointed delegates are going to the Cahoots Lounge, which is on the ground floor, and the description I've been given is that it's behind the wooden doors of the main foyer, close to the Obama image. So if you look at the ground floor, there is a rather fetching photograph of Barack Obama. That's where the Cahoots Lounge is. The Tasmanian delegates, if you could go to the ground floor bar area, so it's in the open but huddling around the bar. And the Queensland delegates, if you could go to the speakeasy, which is also on the ground floor, and I'm told that it is near the restaurant bar and has the sign for the barber shop on the door. So hopefully those instructions all make sense to you all. If you could firstly allow those delegates to have their lunch, move to the briefing rooms to speak with the candidates, and then everyone else to follow with lunch. And rather than reconvening here at 13:30, we'll reconvene about 13:40. So thank you all very much. Enjoy your break.